Okay, we're here today to talk about heart failure. First of all, I just want to make sure that everybody understands heart failure is not the same thing as having a heart attack, right? People seem to get that mixed up, and even students seem to get that mixed up. Heart attack is totally a different thing. Heart attack means that uh, portion of the myocardium has died from not getting enough oxygen. Heart failure just means that the heart is failing to do the job it needs to do, right? It's failing to deliver oxygen to all of the cells. A few different reasons why it might do that. But first of all, I want to kind of show, and usually one side or the other fails. So I'm going to talk about that just a little bit here before we get going too much on the heart. I drew a couple pumps here on the whiteboard. So I've got a pump 1, we got a pump 2, right? So got a hose going from pump 1 over to pump 2, and then from pump 2 back over to pump 1, right? Now, I drew these here to symbolize the left and the right heart, right? It's kind of like having two pumps. Now, what's important to make this, the pumping action of the heart work right is it's important for, they both have to pump the same amount out and at the same rate, right? They got to put it out and they got to put it out at the same rate because they're interconnected, right? Pump 1 is pumping over to pump 2, right? No, it's pumping out its fluid, boom, it's pumping it over here, and this one's pumping at the same time, and it's pumping fluid there, right? So this one here would kind of be like the lungs, so I drew it in blue, and that one could be like the body, it doesn't matter. But, let's say this guy over here, pump 1, is pumping out 4,000 milliliters a minute. And pump 2 is also pumping out 4,000 milliliters per minute. Right? So it's even. It's pumping it over there and it's pumping it back there, right? As long as that's even, it's not really a problem. Let's say the bearings go bad in this pump, right? Get the bearings, things aren't moving as well inside the pump. So it cuts down to 3,000 milliliters a minute. This pump's still working okay, right? So, as this one's pumping out more than this one now, it's pumping it out faster. So what's going to happen if you think about it? Right? You're not putting as much out here as what's coming in here, right? So it backs up. You get pressure backing up back in here, right? And then vice versa. If this guy here failed to pump out as much as this, then you get pressure backing up in here, right? Because this one's pushing it in, and this one's not pushing it out as fast as this one's pushing it in. So you're going to get a buildup in pressure here, right? The way I drew this hell, this one's still working, it's still going at 4,000. Pump 1 is still pumping out 4,000. Pump 2, though, is failing. It's not keeping up. It's only pumping out 3,000. So as this guy here is pumping it in, this guy here isn't pumping it out as fast as this guy's pumping it in. So you're getting a buildup of pressure back in here, right? And that's what you got to remember is that the problem happens behind the side of the heart that's not working well. So if you've got if you've got left-sided heart failure, what's behind the left side, the left ventricle? The lungs, right? So the right side is still pumping into the lungs fast enough if you have left-sided heart failure. The right side's not failing, it's pumping into the lungs, but the left side isn't pumping it out as fast as the right side is pumping it in. So now you get this pressure build up in the lungs. And then they end up with pulmonary edema and they end up out short of breath. If you have right-sided heart failure, right? Now, then that would mean that the right side isn't pumping it out as fast. The left side's still pumping it out. It's pumping it out through the body and it's returning to the right side, but the right side isn't pumping it out as fast. So you get pressure buildup behind the right side. What's behind the right side? Where does the blood come from to get to the right side? It comes from the body, right? So then you get pressure in the body and you end up with edema. You end up with swollen feet and ankles and stuff like that, right? And a lot of other stuff that we'll be talking about. But that's just a real quick synopsis. See, I even drew a little plug in there. See, there's one over here too. Right. Pretty awesome, huh? But anyway, so that's what happens when you get heart failure. Is usually one side or the other fails, and then when the left side fails, and you get increased pressure in the lungs, right? Because left side fails, right side's still pumping into the lungs, left side's not pumping it out. So then you get pressure in the lungs, and then the right side fails, right? Left side fails. Number one reason for right-sided heart failure is left-sided heart failure, right? That one failed, and then it built up pressure in the lungs. Now the right side has to try to pump into that. Can't do it. It's pumping into all this pressure, so it's not pumping very well. And then now you're not moving the blood anywhere, and you end up with pedal edema and a lot of other problems that we'll be talking about. Okay, so there's a couple different ways that the heart can fail. One is systolic failure, and the other one is diastolic failure. So systolic failure is just that. The pumping action of the heart is failing. So the heart's not pumping out as much, right? Heart is failing to pump. So here's the heart. Now when you get a systolic failure, that means that the heart, for some reason, has been weakened. There's several different reasons that you might get it. I got them written down here. Let's see. Cardiomyopathy is one of them. That is a cardiomyopathy. So cardio heart, myo heart muscle, apathy, pathy, right? So pathy is disease. So heart muscle disease. Cardiomyopathy, that's one reason that you might have a systolic failure. Heart's diseased, the muscle is diseased, and it just doesn't have the strength. And next year we'll talk more about cardiomyopathy and the different kinds of cardiomyopathy. But for now, you just need to know that there's heart muscle diseases out there that will weaken the muscle and make it so the muscle does not have the pumping power that it needs to have in order to fulfill the needs. So it fails. And the left side will usually fail first because the left side has more work to do. So it's the side that will fail to do its job first. Another one is coronary artery disease. We just talked about coronary artery disease, right? You got a buildup of plaque, things in the muscle, and so you got different areas of the myocardium that aren't getting enough muscle, they're not getting enough oxygen. They're not getting enough oxygen, so it starts. You get the cardiac cells starting to die, or they're getting injured, and so now they just can't do the job. Right. So that's another reason. So anything like that might cause myocardial cell death can end up weakening the heart. And what happens is the heart fills up and it just doesn't put the blood out very well. So you kind of end up with these guys here. They get kind of stretched out. And thinned out. Wait a minute here. It actually should be bigger here. It's kind of stretched out. Notice I drew them thinner because it's just not as weak as it's strong as what it had been in the past. They're kind of bulging. So you get kind of your heart myocardium kind of gets like that. It's kind of bulged out, and it's weak. Muscles don't fill as well, or the muscles don't contract as well. So the heart gets full, and it just never really can empty itself very well. So your cardiac output is going to be decreased, right? Because you're just not putting enough right? So as top of the heart beats down into the bottom of the heart, right? It fills, and the bottom of the heart beats out. Now it's filled up with blood, but it just doesn't beat out very much. So you got a decrease in your stroke volume. You got a decrease in your cardiac output. You got a decrease in your ejection fraction. So your stroke volume. That piece of shit ain't working. So your stroke volume is decreased. I'm just going to do it like this. Put the arrow there. Much easier. So stroke volume is decreased. Your stroke volume is what? Your stroke volume is the amount of blood pumped out with each beat. So when the amount of blood pumped out with each beat is less, of course your cardiac output is less, because your cardiac output is the amount of blood pumped out of the ventricle in a minute. So if each beat is doing less, pumping out less, when you total that up for your minute, it's going to be less too. So you got a decrease in your cardiac output. Now, your ejection fraction. This thing is filling up. Let's say it's filling up with 100 milliliters, because that's easier to figure out. Your normal ejection fraction depends on where you read it. I've seen 50 to 70, seen 60 to 75. I believe your book says 60 to 75, so we'll go with that. So in order to be in the normal range, it should be, if it fills up with 100 milliliters, it should be pumping out 60 milliliters, right? Well, you've got a decrease in the amount that you're putting out because in each beat, so that means that percentage is going to be less, because that's what the ejection fraction is. The ejection fraction, if you remember right, the ejection fraction is the percentage of blood pumped out of the ventricle with each beat. So if you have 50 milliliters in there and you pump out 25, you're pumping out 50%. So your ejection fraction would be 50, right? If you got 100 milliliters in there and you're pumping out 50, it'd be 50%. Now you got 100 milliliters in there, and let's say we're pumping out 60, since we decided that 60 is what's normal, and it will be 60%. Just a minute here, my wife's calling me. Okay, so we were talking about the systolic failure, which means that the ventricles are not pumping out enough blood, right? They get stretched out. What happens is they keep, well, normally, and the heart dilates itself trying to dilate more so it can pump out more. And what happens is, when we talk about Starling's law, we talk about the fact that when you pull the rubber band back further, right, when you stretch something further back, it releases with more power. In this case here, the myocardium, or the myocardium in the ventricle, it gets stretched out further so that it can pump with more power. The problem is it gets overstretched, right? It's like it got stretched out so far that it's losing its elasticity, it's losing its ability to contract with the normal power that it should have. So it kind of self-defeating there. And that's kind of what happens there with the systolic failure. That's it. And then the other failure that we can talk about is diastolic failure. Well, the first one is the heart fails to pump out the blood at the rate that in the amount that it's supposed to be pumping out. My wife's getting home. So now we'll talk about diastolic failure. Systolic failure, failing to pump well enough. Diastolic failure, failing to fill, right? It's failing to fill well enough. A few different things can lead to diastolic failure. Sometimes the heart loses its elasticity, so it just doesn't relax enough to fill up enough. Another thing that can happen is the heart works, let's say the heart has had to work against high blood pressure for a long time, right? So it's had to work against high blood pressure here for a long time, and as it's pushing, as it's pushing against this increase in resistance, it has to work harder to push the blood out into that system with the high blood pressure. So it ends up doing what all muscle does. It hypertrophies. It gets bigger, right? Same thing. Let's say that you got one of these valves screwed up, right? Do the same thing. If this there valve was stenosed, heart has to push harder to push through there. So it ends up getting hypertrophy, bigger. So now we're coming out like this here. And they got this great big old ventricle there over on the left side, because that's the side it's having to work so hard to push out into the system. So you end up like that. Remember before you had it come down like this, right? So take this here, in fact, like make a point. Let's even make it bigger. So this guy here, there, that's how I like it. So this guy here has really gotten big as it's had to work against this increase in afterload, right? So it's had to really push harder, and it's gotten really bigger and bigger. Well, what do you notice about the size of this ventricle here? It doesn't have enough room to really fill up, right? So maybe it was filling up with 100 milliliters before. Now it's only filling up with 50. Let's say it's only filling up with 50. So doesn't fill up with as much, can't pump out as much, right? Just that simple, right? If it's only filling up with 50, it can't pump out 60, right? It's only going to pump out, and it's only going to pump out a percentage of what it's got. So it's not going to come close to meeting the demands that we had. So what do we got here? We got an decreased stroke volume, right? You're not putting out as much with each pump. If you're not putting out as much with each pump, you're going to have a decreased cardiac output. What about your ejection fraction? What's going to happen to that? Well, now, before we were saying that the heart, let's say, in a normal heart, let's say that you fill up with 100 milliliters of blood, right? Let's take a look at what happens to your ejection fraction, right? Let's say in a healthy heart, you've got 100 milliliters. Yeah, let's say 100 milliliters. And you pump out 60 milliliters. Your ejection fraction is 60%, right? Because we know 60 is 60% of 100. So now let's take a look here at the unhealthy heart. It's not filling well enough, so it doesn't fill up with the 100 milliliters. It only fills up with 50 milliliters. And then let's say it's pumping out 30. For your stroke volume is 30 instead of 60. It's only half of what a healthy heart was. So it's pumping out 30 milliliters for your stroke volume. But if you figure out the percentage, 50 divided by, or 30 divided by 50, you end up with 60%. Right? So your ejection fraction is normal. So you got a normal ejection fraction on this, right? So it's not going to necessarily affect the ejection fraction. Got a decrease in your stroke volume, drop from 60 to 30, right? You got a decrease in your cardiac output, because if you go that 30 times your beats per minute, it's not going to be enough, right? It's still, you're putting out less, but it does not show up in the percentage because you're starting out with a smaller number. So when the problem is that you are not filling well enough, you're not going to see a change in your ejection fraction, right? You won't necessarily see a change. It might change a little, might drop a little, might actually go up a little, but the ejection fraction, the point I'm trying to make is the ejection fraction is an unreliable number when you're trying to figure out how bad it is. In fact, it's a diagnostic value. When a person is in heart failure and their ejection fraction is normal, they know that, okay, this is a diastolic failure. It's not a systolic failure. So I guess so that is a diagnostic value, and will give us the reason for the heart failure. So when we're talking about diastolic failure, like I said, usually the problem is in the left ventricle, and it usually is actually with either systolic or diastolic. but not always. If you have, for some reason, you have a problem in your lungs, if you remember right when we talked about COPD, we actually talked about cor pulmonale. And with cor pulmonale, you have a problem with an increased pressure in your lungs, so it causes your right failure, your right side to fail. And so your right side has to push against that increased pulmonary pressures, and it ends up getting hypertrophied, and it ends up with the failure on the right side. And when the right side fails, what are the symptoms of right-sided heart failure? It's systemic, right? Things back up. You get pedal edema. You get hepatomegaly, right? Your liver ends up getting enlarged and saturated with blood because it's not able to get it out of there and return it. You got this venous JVD, jugular venous distension, that you see there in your neck. And by the way, when you're evaluating a patient and assessing a patient and you're looking at it and you see JVD, that's abnormal if the patient's sitting up or in a semi-Fowler's. But if the patient is lying supine, you can expect to see JVD. So it's not something that you would be alarmed about if they're laying down. Let's see. Problems that you're going to get with heart failure, the edema and everything that I was talking about. If it's right-sided failure, you're going to get edema and all this stuff out in the system. If it's left-sided failure, you're going to get shortness of breath and like the coughing problems. Every time you lay down, your lungs are just going to fill up with fluid, so you got to sit upright all the time to try to keep all that fluid from filling up in your lungs. But we do have compensation, so it can go on for a while. As long as the compensatory mechanisms are able to work, heart failure the system kind of keeps it under control. So when the system is compensating, it will kick in the we've got some noxious stimuli going on. So what happens when that happens? When noxious stimuli is out there, you end up with this sympathetic nervous system activation, right? So your sympathetics, and they're going to release your catecholamines, right? Epinephrine, the main one. Going to increase your contractile force, right? So the heart's going to beat harder. Increase contractility. You're going to increase your heart rate. Right? So hopefully by increasing your contractility, you're going to increase your stroke volume, increasing your heart rate, right? So, and what is your cardiac output? Your cardiac output is your heart rate times your stroke volume. So we should be should be increasing our cardiac output, and that's the whole idea is. Another thing that happens is we end up with vasoconstriction. That's something that happens with the sympathetics, is you end up constricting and pushing, and the way that helps is it pushes more of the blood back into the heart, so it increases your preload. So that's the whole idea behind that. And the other thing that happens is the RAS system is activated. If you remember right, one of the triggers for the RAS system is the sympathetics. Another thing is that when you're not moving blood around very well, like you're not doing with heart failure, it's kind of all backing up and it's not moving, so it's not moving through the kidneys well enough. So the little gauger counters that are counting there and saying how much sodium and water is coming through here says not enough. We need to try to increase that, so it releases renin, kicks in the RAS system. At the end of the RAS system, you end up with, if you remember right, you have the angiotensin 1 end up being converted to angiotensin 2, and that also causes vasoconstriction. Right? You are end up reabsorbing sodium because aldosterone ends up being released, right? So that's renin, angiotensin, aldosterone system. So with the aldosterone, you end up reabsorbing sodium. So lose sodium. So you reabsorb sodium with that. When you reabsorb sodium, you reabsorb water. So you're holding water. That's probably not a good thing, right? So, so now you think about it, this is kind of self-defeating. This works for a little while. It's a compensatory mechanism that can work for a while because it will actually increase your cardiac output. And as long as your heart failure hasn't progressed too much, this compensation works. There's one problem with compensatory mechanisms, and that is when you're already compensating. Right? We have these compensatory mechanisms for a reason. When you get sick, right? You get sick, your body gets stressed for one reason or another. You end up, your system needs to compensate, so it will kick in the sympathetics, or the RAS system will go out there and kick in to try to increase that blood pressure, right? To try to compensate for whatever this stressor is that's happening. Well, now we've already got our compensation going on. So to compensate, it's harder to compensate, right? It's already compensating. So now when the body gets stressed, the person ends up having an acute exacerbation of symptoms with the heart failure. So as this person's compensation has to get stronger and stronger and stronger, it's less able to compensate in times of stress. So then that you end up getting more and more frequent acute exacerbations of heart failure and shortness of breath and all of the signs and symptoms worsening. And as time goes on, the system just loses its ability to compensate. The compensation, like I was saying, it kind of ends up self-defeating because in one sense, the system's already compensating. So in times of stress, it can't really compensate a whole lot more. So it really has a hard time meeting the demands in times of stress. And another thing is, it's just the compensation just starts working. It starts being less and less effective. So as for one thing, the sympathetics, as they're being used over longer and longer and longer, they just kind of lose some of their power. But as the system is doing this vasoconstricting, trying to increase the preload so it can increase its output, the system can end up being more and more stretched out. If you're in a diastolic failure, it actually will make it worse because now you're pushing all this blood back into the ventricles, and the ventricles are getting more and more stretched out, so starting to work less and less well. And with this stretching and everything, it actually gets less blood into the myocardium to feed the myocardium, so you end up with more myocardial cell death, and you end up getting a weaker and weaker heart. So the compensation there is not working as far as the systolic. It also doesn't work as far as the diastolic because it's just trying to push more blood in there. All right, you're vasoconstricting, and what are you doing? You're raising, and you're vasoconstricting, and you're saving your sodium and saving your water, so you're raising your blood pressure. So the problem with pushing blood out against this is worse because the compensatory mechanism is actually making it worse. So then it increases the hypertrophy of the heart, increases or makes it worse. As far as it's trying to beat out into the system. So the diastolic failure actually gets worse, right? As the heart muscle gets larger and larger and get more and more stiff, it can fill. Its ability to fill is actually decreasing. So that's the problem. So then you end up with decompensated heart failure, right? So we're talking about exacerbations of heart failure. We're talking about with more and more decompensation. So as your system starts decompensating more and less and more, In other words, the compensatory mechanisms get less and less effective as time goes on. You're going to get more and more acute exacerbations. So the person is going to, right, in the beginning, you might see this person dumping into the ER, you know, once every 6 months or once a year or something. But as time goes on, they'll get down there to where they're coming in once a week, right? They're coming in, they just can't breathe because they're filling up and they have to get the IV diuretics and all that kind of stuff. And so what I'm saying is heart failure is just one of those things that's going to get worse and worse and worse as time goes on. How do we diagnose heart failure? Well, probably going to do a chest x-ray. What will we see in a chest x-ray? That's supposed to be an R. So what are we going to see in a chest x-ray? Might see some cardiomegaly, right? Also might see the pulmonary edema. All right, so we can see the fluid in the lungs. Another thing we might do is actually, big thing that we can do is we'll do an echocardiogram. Right, a lot of times they'll do a transesophageal echocardiogram where they'll go down and look through the esophagus and look at the heart there so they can get a better view of it, not trying to go through the sternum and all the ribs and all that stuff. The sound waves will give you a better picture. So this is how we get our ejection fraction, and we just found out that's kind of important to know what your ejection fraction is. But echocardiogram is how we get that, right? But when we can actually watch chambers contract, we can see how good a job they're doing at contracting. We can see what the stroke volume is, right? Anyway, the echocardiogram gives us a good view of what's going on in the chambers and how the blood is going through them. Let's see, labs. Right. BNP. There is ANP too, but BNP is the main one. BNP stands for brain natriuretic peptide. The brain is actually a misnomer. This is released in the ventricles. When the ventricle myocardium gets overstretched, it releases BNP. What BNP does is it kind of fights against the RAS stuff, right? And so it can go out there and it can vasodilate, and drop the blood pressure so that the overstretched myocardium, more blood will be out in the system instead of in there. It can decrease the RAS system, so hopefully you will increase the amount of urine, so you're getting rid of so it can start getting rid of some of your fluid. So BNP gets elevated when the ventricles get overstretched. So during heart failure, your ventricles are getting stretched out. So your BNP will be elevated. Your normal BNP should be less than 100. If your BNP is less than 100, it's normal. If it is 100 to 300, well, you may have failure. It's not a real sure thing yet. If it's 300 to 900, you got heart failure. If it's greater than 900, you got severe heart failure. All right. So BNP is the most important lab out there. There's a whole lot of other labs that you're going to be doing. You're going to be doing your electrolytes because you want to see what's happening with your sodium and potassium, mainly because when RAS system is being kicked in, and then the natriuretic peptides get kicked in. You are changing the way you would normally be holding on to sodium and getting rid of potassium. So you definitely want to take a look at that too, right? And they always will do a CBC just to see where you're standing on all of your blood and all of your red blood cells and white blood cells and see where that count is. So now we'll talk about classifying. Okay, so when this person here is, I'm going to put a little table here. When they're at rest, and with activity. So, under the class system, if they're a 1 would mean that at rest they're fine, no symptoms, and with activity, no symptoms. No change, right? No change, so they're fine. And number 2 means at rest they're fine. And with activity, there's a little bit of change, right? Not a lot, but some. I'll just put some change. Not debilitating. They can still carry on with your business. At number 3, right? At rest, they're still fine. But with the slightest amount of activity, they get lots. Well, actually, with some activity, they get lots of symptoms. And class number 4. It's supposed to be a 4. At rest, they have symptoms. That's the big deal here. Even at rest, people are working to breathe. These are the people that you see sitting there and they just can't breathe, even when they're not doing anything. And when they go into activity, they have extreme acute exacerbation of symptoms. Okay? Now, I guess the American Heart Association wasn't happy with that because it's all focused so much just on activity and exercise, right? They can actually do a test here where they can actually exercise the person and watch this stuff, right, and see how they react. So we're going to be identifying with the staging, try to identify people who are at risk for heart failure and how the disease is progressing. So their stages. A means they're at risk. They have a high risk, but they don't have any heart disease yet, right? They can't see any failure, don't see any any changes in the person's heart. So at this time here, they have this guy here. The person at risk might be somebody who has known coronary artery disease. You don't see any changes in the heart and the structure of the heart, but they have coronary artery disease. But you don't see any. There's no thickening of the walls or no thinning of the walls or anything like that. Might be somebody also with hypertension, right? They might have high blood pressure, so they know that they have a risk, right? Diabetics also have a risk. So these are people who have a risk of heart failure but just don't have it yet. But there's no structural changes. So now in B, these are people here who have structural changes to the heart. Structural change. But they don't have any symptoms. No symptoms yet, right? So when you look here, the reason they like doing this staging over the other classification one that we were talking about before is they like to see what they can do in each one of these stages. So right here, when the person is at risk, you're going to try to exercise. You're going to try to decrease their risk. Maybe you'll get them doing some exercising, right? Might have to put them on statins. What are statins? Right? Simvastatin. There is drugs that lower cholesterol. So you might have to get them some kind of cholesterol medicines. Control their blood pressure. Right? Either with diet and exercise or with um, medicines. Decrease salt intake. Sodium intake. Right? And these are all things that they might do. Control their blood pressure, they might put them on an ACE, right? Because we know that we were talking before about the RAS system has kicked in, so I want to put them on an ACE inhibitor or a beta blocker, right? Beta blocker can, an ACE inhibitor will block the RAS system, and a beta blocker would block the sympathetics. And both of those are compensatory mechanisms that end up being self-defeating. So now down here, you got this guy here. He's got some structural changes there in the heart. You might be starting to see some of the cardiomegaly, or start to see some of the problems that you see in the heart. But you're going to try to so they might have cardiomegaly. They might have a decrease in ejection fraction. Okay, so now number C, stage C. They'll have structural changes, of course. And they'll have some symptoms with activity. This person here is still compensating. Right? This guy up here is compensating. Oh, this guy here doesn't have the structural changes. Here, they got the structural changes. They're still compensating for, but they're compensating for it. Now, D. So they have the structural changes, of course. And they will have advanced symptoms. Advanced symptoms. Right? So this is the person, he's starting to decompensate. Right? This person is decompensating. They may need some aggressive treatments, right? They'll need, this guy up here is definitely going to be on medications. This guy down here is probably going to need monitoring, home monitoring. With daily weights. That will be automatically go to the doctor's office, right, when they have their exacerbations, and of course that's going to take a lot of really aggressive treatment too. Both of these guys here are probably going to be put on diuretics. Like they'll be put on things like furosemide, and that decreases their potassium. So then a lot of times they'll put them on like spironolactone. To save some of that potassium. And like I was saying before, the ACE inhibitors and beta blockers, when they're down here, they're decompensating. You probably don't want to use the beta blockers because their compensatory mechanisms are failing. You don't really want to decrease what they're doing. Okay. Okay, when you have acute exacerbations, decompensated heart failure, you have to be you're aggressive. You have to be aggressive with your treatment, of course. And they will usually give some IV Lasix. Might give some spironolactone. ACE inhibitors. I want to give some calcium channel blockers too. It's a maybe. And that would just be to decrease blood pressure. And not beta blockers. I'm just going to put that there. Not in when they are decompensating. Another thing is here that you might person as they decompensate and the heart is getting weaker and weaker, the ventricular assist devices are one of the things, and that's those pumps that they actually will implant in there, and it takes the blood from the I believe it takes it from the, let's see, well, it can be an LVAD or an RVAD. An LVAD is actually what you probably see the most where it's helping the blood, and it just takes the blood and helps pump it through. And they usually have like a control device outside the body here where you can mess with it. When the thing to know about these people here is when they have one of these in, you won't feel a pulse, right? Because it's just pushing the blood, just pumping the blood through there. So you might feel a little bit of a pulse underneath that constant blood flow, but it wouldn't be surprising at all, and don't expect to feel a pulse on one of these people. So we're going to be identifying with the staging, try to identify people who are at risk for heart failure, and how the disease is progressing. So their stages. A means they're at risk. They have a high risk, but they don't have any heart disease yet, right? They can't see any failure, don't see any functional changes in the person's heart. So at this time here, they have this guy here. The person at risk might be somebody who has known coronary artery disease. You don't see any changes in the heart and the structure of the heart, but they have coronary artery disease, but you don't see any, there's no thickening of the walls or no thinning of the walls or anything like that. Might be somebody also with hypertension, right? They might have high blood pressure, so they know that they have a risk, right? Diabetics also have a risk. So these are people who have a risk of heart failure but just don't have it yet. but there's no structural changes. So now in B, these are people here who have structural changes to the heart. Structural change. But they don't have any symptoms. No symptoms yet, right? So when you look here, the reason they like doing this staging over the other classification one that we were talking about before is they like to see what they can do in each one of these stages. So right here, when the person is at risk, you're going to try to exercise. You're going to try to decrease their risk. Maybe you'll get them doing some exercising, right? Might have to put them on statins. What are statins? Right? Simvastatin. There's drugs that lower cholesterol. So you might have to get them some kind of cholesterol medicines. Control their blood pressure. Right? Either with diet and exercise or with medicines. Decrease salt intake. Sodium intake. Right? And these are all things that they might do. Control their blood pressure, they might put them on an ACE, right? Because we know that we were talking before about the RAS system has kicked in, so I want to put them on an ACE inhibitor or a beta blocker, right? Beta blocker can, an ACE inhibitor will block the RAS system, and a beta blocker would block the sympathetics. And both of those are compensatory mechanisms that end up being self-defeating. So now down here, C, stage C, they'll have structural changes, of course. And they'll have some symptoms with activity. This person here is still compensating. Right? This guy up here is compensating. Well, this guy here doesn't have the structural changes here. They got the structural changes. They're still compensating for, but they're compensating for it. Now, D. So they have the structural changes, of course. And they will have advanced symptoms. Advanced symptoms. Right? So this is the person, he's starting to decompensate. Right? This person is decompensating. They may need some aggressive treatments, right? They'll need, this guy up here is definitely going to be on medications. This guy down here is probably going to need monitoring, home monitoring. With daily weights. That will be automatically go to the doctor's office, right, when they have their exacerbations, and of course that's going to take a lot of really aggressive treatment too. Both of these guys here are probably going to be put on diuretics, like they'll be put on things like furosemide, and that decreases their potassium, so then a lot of times they'll put them on like spironolactone. To save some of that potassium. And like I was saying before, the ACE inhibitors and beta blockers when they're down here, They're decompensating. You probably don't want to use the beta blockers because their compensatory mechanisms are failing. You don't really want to decrease what they're doing. You have acute exacerbations, decompensated heart failure. You have to be you're aggressive. You have to be aggressive with your treatment, of course. And they will usually give some IV Lasix. Might do some spironolactone. ACE inhibitors. I want to give some calcium channel blockers too. That's a maybe. And that would just be to decrease blood pressure. And not beta blockers. I'm just going to put that there. Not in when they are decompensating. Another thing is here that you might person as they decompensate and the heart is getting weaker and weaker, the ventricular assist devices are one of the things, and that's those pumps. Anyway, it just takes the blood and helps pump it through. And they usually have like a control device outside the body here where you can mess with it. When the thing to know about these people here is when they have one of these, and you won't feel a pulse, right? Because it's just pushing the blood, just pumping the blood through there. So, you might feel a little bit of a pulse underneath that constant blood flow. But it wouldn't be surprising at all, and don't expect to feel a pulse on one of these people.